Good evening, everyone. I am Dr. Satyabrata, MDDM clinical pharmacologist, and today I am going to discuss on biotransformation of drugs. So, this is the compartment. This is the method by which biotransformation occurs. This picture shows how drug is first of all liberation. There will be then absorption, then metabolism and excretion. That is ADME, and the free drug will be the active drug that will uh, give the action, and uh, there will be equilibrium between bound and free form in case of unwanted site of action, and in the tissue reservoirs bound uh, form is in equilibrium with free form, and therapeutic site of action receptors there is bound form in equilibrium with free form. So then protein bound of the drug also uh, reduce the free drug, and the excretion and metabolites that are also excreted from the body, and uh, there will be clearance, and this total image is under the biotransformation. So coming to genobiotics means foreign chemicals humans are exposed to, that is present in foods and drink ingested intentionally, processed foods, food additives, drugs, or unintentionally environmental pollutants and agrochemicals. And genobiotics are cosmetic products can be absorbed across the skin, and drugs used for therapeutic and recreational purposes. These are also comes under genobiotics. Then genobiotic metabolizing enzymes, potential ramifications and use in drugs development. They are responsible for inter-individual variations, DDI, that is drug-drug interactions, chemicals, toxic and carcinogenic derivatives, and their limits used in animal models. So drugs are genobiotics and they use the same enzymatic pathways and transport system that are used for normal metabolism of dietary constituents. Then the primary site and other site of biotransformation, sites of drug biotransformation. This image, it can be in the gastrointestinal tract, that is absorb orally administered drugs. In case of liver, hepatic metabolism or fast pass effect, the most important organ in drug metabolism, and some drugs may decrease oral viability like lidocaine, that is ineffective isoproterenol, meperidine, morphine, nitroglycerin, pentazocine, propoxyphene, propranolol, salicylamide. These can undergo hepatic fast pass metabolism, and the viability decrease due to fast pass metabolism. So blood circulation is also site of biotransformation, absorbed orally administered drugs, uh, and this picture actually shows the sites of drug biotransformation very briefly. Then coming to biotransformation of drugs, biotransformation of drugs um, can can be many types, like inactivation of drugs. In some cases, active metabolite from an active drug is produced, and in some cases, the activation of inactive drugs. Then, in inactivation, most drugs and their active metabolites are rendered inactive or less active. For example, ibuprofen, paracetamol, chloramphenicol, propranolol, and its active metabolite 4-hydroxypropranolol. And from active metabolite from an active drugs, many drugs have been found to be partially converted to one or more active metabolite. So active drugs like chloral hydrate, they are converted to active metabolite like trichloroethanol. And morphine is active drug, but the active metabolite is morphine 6 glucuronide. Cefotaxime is the active drug, active metabolite is des acetyl cefotaxime. Allopurinol is the active drug, active metabolite alloxanthine. Procainamide, the active drug, active metabolite N-acetyl procainamide. Primidone is the active drug, active metabolite phenobarbital, phenyl ethyl malonamide. Diazepam is the active drug, active metabolite is desmethyl diazepam oxazepam. Digitoxin is the active drug, active metabolite digoxin. Imipramine is the active drug and active metabolite desipramine. Amitriptyline is the active drug and active metabolite nortriptyline. Codeine is the active drug and active metabolite is morphine. Spironolactone is the active drug and active metabolite of spironolactone is canarinone. So active drug is losartan and active metabolite of losartan is E3174. So these are some examples of active metabolite from an active drugs. Then activation of inactive drugs, that is prodrug. Prodrug, what you mean by prodrug? Few drugs are inactive and need conversion in the body to one or more active metabolites. The advantage of prodrug is that these are more stable and they are having better bioavailability, desirable pharmacokinetic properties, they are having less side effects and toxicity, and they are activated selectively at the site of action. So these are some advantages of prodrug. So coming the examples, prodrug that are form into active form, levodopa, that is a prodrug, that is active form is dopamine, and the levodopa is used, in Parkinsonism. And enalapril. Enalapril is the prodrug which is whose active form is enalaprilat. It is an ACE inhibitor, angiotensin converting enzyme inhibitor, that is used in the case of hypertension and etc. But nowadays the use is very less. Then prodrug is alpha methyl dopa. Alpha methyl dopa active form is alpha methyl norepinephrine, and this is also a drug used in hypertension. Prodrug dipifeprin. Dipifeprin is a prodrug, that is the active form is epinephrine, and sulindac is a prodrug, the active form is sulfide metabolite. Proguanil is a prodrug, the active form is cycloguanil. Prednisone is a prodrug, the active form is prednisolone. Bacampicillin is a prodrug, the active form is ampicillin. Sulfasalazine is a prodrug, the active form is 5-amino salicylic acid. Cyclophosphamide is a prodrug, the active form is aldophosphamide, phosphormide mustard, acrolein. Fluorouracil is a prodrug, active form is fluorouracil monophosphate, and mercaptopurine is a prodrug, active form is methyl mercaptopurine ribonucleotide. Acyclovir is a prodrug and active form is acyclovir triphosphate. So these are some examples of prodrug that is that activated in the body to cause the effect. So then coming to the classification, biotransformation reactions can be classified into one is non-synthetic oblique phase 1 functionalization reactions. A is non-synthetic oblique phase 1 oblique functionalization reactions. Another is B, that is synthetic oblique conjugation oblique phase 2 reactions. Synthetic oblique conjugation oblique phase 2 reactions. So this is the picture showing how drugs are absorbed, metabolism, and eliminated from the body by and lipophilic drugs are more absorbed and they have to converted into hydrophilic for elimination, and that's why phase 1 phase 1 biotransformation and phase 2 phase 1 cause drug metabolite with modified activity, and inactive drug metabolites, they are conjugated then eliminated, and in phase 2 the conjugation is there. Every drug in phase 1 drug, some drugs directly goes phase 2 biotransformation and eliminated from the body. Some drugs go first phase 1, then undergo phase 2 biotransformation and eliminated from the body in hydrophilic form. So this is a good picture taken from Carjun, and it is very essential for students. So phase one reaction is a functional group containing OH, hydroxyl COH, carbo, C hydro and CHO aldehyde and NH2 amine and SH sulfide is generated oblique exposed. And in phase 1, the metabolites formed may be active or inactive, and the it is also called non-synthetic reactions. These are oxidation, reduction, hydrolysis, cyclization, decyclization. So in case of phase 2, an endogenous radical is conjugated to the drug and the metabolites mostly formed are inactive. But the exceptions are glucuronide conjugate of morphine and sulfate conjugate of minoxidil. Then coming to synthetic reactions are the phase 2 reactions or phase 2 biotransformation that include the glucuronidation, acetylation, methylation, sulfate conjugation, glycine conjugation, glutathione conjugation, ribonucleoside nucleotide synthesis. Coming to non-synthetic reactions, first of all, oxidation. The definition is that addition of oxygen or negatively charged radical or removal of hydrogen H2 oblique positively charged radical is known as oxidation. So most important drug metabolizing reactions is oxidation, and phase 1 oxidation reactions are carried out by CYP cytochrome P's and FMOs, fluorine monoxidases, and esterases. So, for example, hydroxylation, oxygenation at carbon, nitrogen, and sulfur atoms, and O-dealkylation and oxidative deamination. These are examples of oxidation. Then process. How it is processed, the biotransformation. Microsomal drug oxidations require P450, P450 reductase, NADPH, and molecular oxygen, and oxidized Fe2 plus P450 combines with a drug substrate to form a binary complex, and NADPH here donates an electron to the flavoprotein P450 reductase, which in turn reduces the oxidized P450 drug complex. And a second electron is introduced from NADPH via the same P450 reductase, which serves to reduce molecular oxygen and to form an activated oxygen P450 substrate complex. This complex in turn transfers activated oxygen to the drug substrate to form the oxidized product. So this image shows that flavoprotein oxidized flavoprotein reduced NADPH, NADP plus, and drug RH in one step 1 P450 to P450 RH AP3 plus, and electron 2 electron minus P450 RH AP2 plus, and CO carbon presence of carbon monoxide P450 RH AP2 plus carbon monoxide complex, and then in presence of oxygen electron minus P450 RH Fe2 plus oxygen, then 2H plus presence turns into H2O, and P450 ROH Fe3 plus is formed, and this after that ROH is eliminated from this, and the P450 Fe3 plus is formed. This is a cyclical process. Flavoprotein oxidized flavoprotein reduced, and you can go through the different books and articles to learn more about this process of uh, oxidation and reduction also, and you can go through different books to learn more about this. So cytochrome P, CYP isoenzymes important in man are CYP3A45, CYP2D6, CYP2C89, CYP2C19, CYP1A1 by 2. So the relative this picture shows the relative contribution of cytochromes to drug biotransfer. That is, most drugs are involved with cytochrome uh, CYP3A. That is 55% of the drugs biotransfer through CYP3A, and then the yellow is given CYP2D6, that is 25 to 30%, and CYP2E1, it is 2%, CYP1A2, it is 3%, and CYP2C, it is 15 to 20%. So 55% in CYP3A, CYP2D6 25-30%, CYP2C 15 to 20%, CYP2U1 2%, CYP1A2 3%. So like this, CYPs are involved in biotransformation. Then coming to importance of CYP cytochrome P isoenzymes, that is substrate specificity, the very low during drug metabolism. The substrate specificity is very low during drug metabolism, and high lipid solubility of the substrate, and a sluggish catalyst, that will do the drug biotransfer slow. If there is sluggish catalyst, acts as sluggish catalyst, and but drug biotransfer slow. Gene arrays combined with immunoblotting analysis of microsomal preparations, as well as the use of relatively selective functional markers and selective P450 inhibitors, have identified numerous P450 isoforms. So these are the importance of CYP isoenzymes. Naming of CYP enzymes: CYP3A4 means here family is 3 and subfamily is A, and gene number is 4, and P means CYP, CY means cytochrome, P means pigment. So these are some cytochromes that are present in the body, that are esterases, CYP 3A4/5, CYP2U1, CYP2D6, CYP2C10, CYP2C8/9, CYP2B6, CYP2A6, CYP1B1, CYP1A1/2, and DPYD, epoxide hydrolase, esterases, others. So coming to participation of the CYP enzymes in metabolism of some clinically important drugs. CYP enzyme, examples of substrates. So CYP1A1, that is, examples are caffeine, testosterone, and R-warfarin. CYP1A2, the examples are acetaminophen, caffeine, phenacetin, R-warfarin. And CYP2A6, the examples are 17-beta estradiol, testosterone. CYP2B6, the examples are cyclophosphamide, erythromycin, testosterone. CYP2C family, acetaminophen, examples are acetaminophen, tolbutamide, tolbutamide 2C9, hexobarbital, S-warfarin 2C9 and 19. Then phenytoin, testosterone, R-warfarin, 0 2C8, 9, 19. And 2E1 in cytochrome 2E1, CYP2E1, the examples are acetaminophen, caffeine, chlorjoxazone, halothane. CYP2D6, for example, acetaminophen, codeine, and debrisocui. These are the drugs. These are the examples of the substrates. 3 CYP3A4, the examples of substrates are acetaminophen, caffeine, carbamazepine, codeine, cortisol, erythromycin, cyclophosphamide, S and R warfarin, phenytoin, testosterone, halothane, zidofudine. Then this table shows the inducers and inhibitors, CYP inducers and CYP inhibitors. So CYP3A4 inducers, examples are barbiturates, carbamazepine, glucocorticoids, pioglitazone, phenytoin, rifampin. And CYP3A4 inhibitors are clarithromycin, diltiazem, erythromycin, fluconazole, grapefruit juice, itraconazole, ketoconazole. And CYP1A2 inducers are smoking, cruciferous vegetables, omeprazole, and CYP1A2 inhibitors are galangin, puraphyllin, fluvoxamine. And CYP2A6 inducers are rifampin, phenobarbital. CYP2A6 inhibitors are tranylcypromine, menthofuran, methoxyzalline. And CYP2C9 inducers are barbiturates, rifampin, inhibitors are sulfaphenazole. CYP2C19 inducers are barbiturates rifampin. CYP2C19 inhibitors are benzyl phenobarbital fluconazole. CYP2E1 inducers are ethanol isoniazid. CYP2E1 inhibitors are 4-methyl-pyrazole disulfiram. Then coming to FMO, that is flavin containing monooxygenase, the superfamily of phase 1 enzymes. These are the superfamily of phase 1 enzymes involved in drug metabolism and minor contributors in drug metabolism. These are having minor contribution in drug metabolism, and they never produce toxic metabolite. So they neither easily induced or inhibited by xenobiotic receptors, and they have no significant role in DDIs, that is drug-drug interactions. And these are having 6 families. FMO3 is most abundant in liver. Then coming the EHS, hydrolytic enzymes. EHS, that is hydrolytic enzymes. Two forms, SEH and MEH, carry out hydrolysis of epoxides. For example, carbamazepine, CYP, carbamazepine 10, 11 epoxide EHS. EHS, that is hydrolytic enzymes. In presence of hydrolytic enzymes, dihydrodiol. Going to dihydrodiol. Then coming to another phase 1 reaction, that is reduction. Reduction, this is the converse of oxidation and involves cytochrome P450 working in the opposite direction. For example, chloral hydrate, chloramphenicol, halothane, warfarin, etc. Then coming to another method of phase 1 reaction, that is hydrolysis. This is cleavage of drug molecule by taking up a molecule of water esterase, and ester plus H2O, water, acid plus alcohol, amides and polypeptides hydrolyzed by amidases and peptidases, epoxide metabolites by epoxide hydrolases, and epoxide metabolites by epoxide hydrolases, and the sites. The sites are in liver, intestines, plasma, and other tissues. For example, choline esters, procaine, lidocaine, procainamide, aspirin, and indomethacin, pethidine, and oxytocin. These are undergoing hydrolysis. So, then coming to another is cyclization, that is formation of ring structure from a straight chain compound. For example, proguanyl converted to cycloguanyl. Then another is decyclization, uh, and opening of, that is opening of ring structure of the cyclic drug molecule. For example, barbiturate and phenytoin, etc. So then we will discuss on synthetic reactions, that is phase 2 reactions. One is glucuronide conjugation. Glucuronide conjugation is the most important synthetic reaction in the biotransformation, and it is carried out by UDP glucuronyl transferase, that is UGTs. So compounds with a hydroxyl or carboxylic acid group are easily conjugated with glucuronic acid, which are derived from glucose. And drug plus UDPGA, UDPGA in presence of UDPGT, that is UDP glucuronosyl transferase, uh, that leads to converted to drug glucuronide plus UDP, that is UDP glucuronosyl UDP. So, for example, chloramphenicol, aspirin, paracetamol, diazepam, lorazepam, morphine, metronidazole. These are the drugs that undergo glucuronide conjugation. Then other utilize this pathway are endogenous product of substrate like bilirubin, steroid hormones, and thyroxine. And glucuronidation increases molecular weight of drug and favors its excretion in the bile and can be hydrolyzed by bacteria in the gut. Then enterohepatic circulation of drug prolongs its action. For example, phenolphthalein, oral contraceptives, they undergo enterohepatic circulation. Then enterohepatic cycling. Enterohepatic cycling, drug glucuronide excreted in bile can be hydrolyzed by bacteria in the gut. The liberated bacteria is reabsorbed and undergoes the same fate. That prolongs the duration of action in case of phenolphthaleins and OCP, oral contraceptive pills. Other drugs examples are chloramphenicol, aspirin, paracetamol, diazepam, lorazepam, morphine, metronidazole. So this is the picture showing the enterohepatic cycling of drugs, how it occurs. The drug get deconjugate. The drug will be deconjugates, help in uh, reduce the drug gluconate conjugation to drug, and that enters into the portal vein and goes to the liver, and the liver the drug will further get conjugated with gluconate GD and OATP involving there, and then enter into the systemic circulation. Then it enters to the to kidney. In kidney GF in presence of OATP drug gluconate conjugation, uh, it will it will eliminated in the urine, and in the gut there will be drug gluconate conjugation. uh, the drug will be reduced by bacterial deconjugation, and the drug will be eliminated through the feces. So, and the drug conjugate and gluconide and drug both are eliminated through the feces. So this is a cyclical process called enterohepatic drugs, cycling of drugs. Portal vein enter into liver, and from the bile duct it enters into the gut. So this is a cyclical process, and from liver enter into the systemic circulation to the kidney, then excreted through the urine. So this is the enterohepatic cycling of drugs. Then acetylation. Acetylation, the compounds having amino or hydrogen residues are conjugated with the help of acetyl coenzyme A. For example, sulfonamides, INH, isoniazid, PAS, paraminosalicic acid, dapsone, hydralazine, clonazepam, procainamide. These are undergone acetylation. Then rate of acetylation shows genetic polymorphism. Genetic polymorphism, a true genetic polymorphism is defined as the occurrence of a variant allele of a gene in population frequency of approximately 1%, resulting in altered expression of or functional activity of the gene product of both. Genetic polymorphism includes slow acetylators, that is, for example, isoniazid 60% of Indians are slow acetylators, and fast acetylators, for example, isoniazid 40% of Indians are fast acetylators. Then methylation, the amines and phenols can be methylated by methyl transferases, methyl donors, that is methionine, cysteine, and for example, adrenaline, histamine, nicotinic acid, methyl dopa, captopril, morcaptopurine, these are for example of methylation. Then sulfate conjugation. Sulfate conjugation, for example, phenolic compounds and steroids undergo sulfate conjugation. Both are sulfated by sulfotransferases known as SULTs. And for example, chloramphenicol, methyl dopa, sex steroids are also undergo sulfate conjugation. Then glycine conjugation. Glycine conjugation examples salicylates, nicotinic acid, glycine conjugation, etc. And then coming to glutathione conjugation. Glutathione conjugation is carried out by GST, glutathione S transferase. This is the minor pathway, and it inactivates highly reactive quinone epoxide intermediates, for example paracetamol. But when large intermediates formed, then glutathione supply falls and toxic adducts are formed with tissue constituents, which results in hepatic, renal, and other tissue damage. Then coming to ribonucleoside nucleotide synthesis. This pathway is important for the activation of many purines and pyrimidine antimetabolites used in cancer chemotherapy. So this is the examples of phase 2 reactions like glucuronidation, endogenous reactant type of conjugation, that is glucuronidation. Endogenous reactant involved with UDP glucuronic acid, and transferase location UDP glucuronic microsomes. Types of substrates: phenols, alcohols, carboxylic acids, hydroxylamines, sulfonamides. Examples of glucuronidation drugs under glucuronidation are nitrophenol, morphine, acetaminophen, diazepam, N-hydroxydapsone, sulfathiazole, meprobamate, detoxin, deoxin. And then coming to acetylation, acetyl CoA is the endogenous reactant, transferase, N-acetyl transferase cytosol, types of substrate amines, and examples of drugs are undergoing acetylation are sulfonamides, isoniazid, clonazepam, grafton, mescaline. Then glutathione conjugation, types is glutathione conjugation, endogenous reactant is glutathione GSH, transferase location GSH, S transferase, cytosol microsomes, types of substrates, epoxides, iron oxides, nitro groups, hydroxylamines. For examples, acetaminophen, ethacrylinic acid, bromobenzene. Then glycine conjugation, endogenous reactant glycine, transferase acetyl CoA, glycine transferase mitochondria, types of substrates, acetyl CoA derivatives of carboxylic acids. For example, salicylic acid, benzoic acid, nicotinic acid, cinnamic acid, cholic acid, deoxycholic acid. Then sulfation endogenous reactant is phosphoadenosyl phosphosulfate. Transferase location is transmit is sulfotransferase cytosol. Then types of substrate phenols, alcohols, aromatic amines. Then for example, drugs are estrone, aniline, phenol, 3-hydroxycoumarine, acetaminophen, methyl dopa undergo sulfation. Then methylation endogenous reactant is S-adenosyl methionine and transfer location is transmethylase cytosol. Types of substrates catecholamines, phenols, amines. Examples are drugs dopamine, epinephrine, pyridine, histamine, thiazide. Then water conjugation endogenous reactant is water. Transferase location is epoxide hydrolase, microsomes, cytosol. Then microsomes, types of substrates are in oxide cis desubstituted and monosubstituted oxidants. Then examples are benzopyrene, 7,8 epoxide, styrene, 1,2 oxide, carbamazepine epoxide. In cytosol, there is types of substrates are alkene oxides, fatty acid epoxides. Examples are leukotriene A4. So you can go through different books to learn more about phase and phase two reactions. So then what is stereoisomers? Stereoisomers, they are metabolized differently and at different rates. For example, S warfarin undergo ring oxidation and R warfarin undergo side chain reduction. And the drugs metabolized by enzymes of intermediary metabolism, alcohol by alcoholic dehydrogenase, and allopurinol by xanthine oxidase, succinyl choline and procaine by plasma pseudocholinesterase, and noradrenaline by monoamine oxidase. So these are some examples of drugs metabolized by enzymes of intermediary metabolism. Then drugs metabolizing enzymes. Two types. One is microsomal enzymes, another is non-microsomal enzymes. So similarities, they show genetic polymorphism. Both are deficient in newborn, especially premature, so they are susceptible to many drugs like chloramphenicol, opioids. So dissimilarities in microsomal enzymes, non-microsomal enzymes. Non-microsomal enzymes are located in smooth endoplasmic reticulum (ACR), primarily in the liver, also present in kidney, intestinal mucosa, and lungs. And but non-microsomal enzymes locations are in the cytoplasm and mitochondria of hepatic cells. Then examples of microsomal enzymes are monooxygenase, cytochrome P450, UGTs, uridine glucanosyl transferase, then epoxide hydrolase. Then non-microsomal enzymes examples are esterase, amidase, flavoprotein oxidase. And microsomal enzymes, they catalyze most of the oxidations, reductions, hydrolysis, and glucuronide conjugation. Non-microsomal enzymes, they catalyze some oxidations and reductions and all conjugations except glucuronidation. Microsomal enzymes are inducible, but non-microsomal enzymes are non-inducible. You can induce microsomal enzymes, but non-microsomal enzymes are non-inducible. So you can go through different books to learn more about these microsomal enzymes and non-microsomal enzymes. And microsomal enzyme inducers and enzyme inhibitors. Some drugs can inhibit or induce the microsomal enzymes, thereby increasing chances of drug toxicity or failure, respectively. So enzyme inducers, There are some examples given here, that is isofulvin, rifampicin, alcohol, benzopyrene, DDT, St. John's wort, phenytoin, phenobarbital, primidone, carbamazepine, cigarette smoke. These are enzyme inducers. And the examples of enzyme inhibitors are quinidine, isoniazid, inhibitors of protease, cimetidine, and chloramphenicol, ciprofloxacin, ketoconazole, itraconazole, fluconazole, valproate, erythromycin, grapefruit juice, DEC, diethylcarbamazine, delaviridine, disulfiram. These are enzyme inhibitors. Then inhibition of drug metabolism. One drug can competitively inhibit the metabolism of another if it utilizes the enzymes and cofactors. For example, azole plus macrolide binds to heme iron in QIP 450 and binds to heme iron in QIP 450, uh, inhibit the metabolism of many drugs and endogenous substances like steroid and bilirubin. So if a drug inhibits its own metabolism, the oral bioavailability is likely to increase for high fast metabolism, but system clearance is likely to decrease, thus prolonging plasma half-life. For example, verapamil is nearly doubled and DHAP is prolonged because it inhibits its own metabolism. A drug may also inhibit one isoenzyme while being itself a substrate of another isoenzymes. For example, quinidine is metabolized mainly by CYP3A4 but inhibits CYP2D6. For example, quinidine is metabolized mainly by CYP3A4 but inhibits CYP2D6. Then the table shows drugs that inhibit drug metabolizing enzymes. So these drugs are allopurinol, omeprazole, erythromycin, clarithromycin, chloramphenicol, ketoconazole, itraconazole, metronidazole, ciprofloxacin, sulfonamides, fluoxetine, and other SSRI selective serotonin reuptake inhibitors, amiodarone, propoxyphene, isoniazid, cimetidine, quinidine, disulfiram, liltiazem, verapamil, MAO inhibitors, monoamine oxidase inhibitors like selegiline, rasagiline, etc., and ritonavir and other HIV protease inhibitors. HIV, human immunodeficiency virus protease inhibitors. And metabolism of drugs with high hepatic extraction is dependent on liver blood flow, called as blood flow limited metabolism. It is very important that metabolism of drugs with high hepatic extraction is dependent on liver blood flow, called as blood flow limited metabolism. So you can go through different books to learn more about this. So then coming to induction of drug metabolism, many drugs plus insecticides plus carcinogens, they increase the synthesis of microsomal enzyme protein, especially cytochrome P450. So for example, anticonvulsants, phenobarbital, phenytoin, carbamazepine, rifampicin, glucocorticoids induce UIP3A isoenzymes. Then phenobarbital and rifampicin also induce UIP2C8 by 9. Carbamazepine and rifampicin in addition induce UIP2C19 and UIP1A1 by 2. Isoniazid and chronic alcohol consumption induce UIP2E1. Polycyclic hydrocarbons induce UIP1A isoenzymes. So, these are some examples of induction of drug metabolism. Induction involves microsomal enzymes in liver as well as other uh, organs, and this increases the rate of metabolism by 2 to 4 folds. Induction takes 4 to 14 days to reach its peak and is maintained till the inducing agent is being given. Thereafter, enzymes return to their original value over 1 to 3 weeks. Consequences of microsomal enzyme induction: there is decreased intensity or duration of action of drugs that are inactivated by metabolism. For example, failure of contraception with OCP, oral contraceptive, and loss of anti-HIV immunodeficiency virus action of nevirapine due to rifampicin co-administration. Then another example is increased intensity of action of drugs that are activated by metabolism. For example, acute paracetamol toxicity occurs at lower doses in patients receiving enzyme inducers. Then coming to tolerance. Tolerance, if the drug induces its own metabolism, autoinduction, it is called autoinduction. For example, carbamazepine, rifampin, nevirapine dose needs to be doubled after 2 weeks. In case of carbamazepine rifampicin use, nevirapine dose needs to be doubled after 2 weeks. Some endogenous substrates like steroids, bilirubin are also metabolized faster. Then precipitation of acute intermittent porphyria. Enzyme induction increases porphyrin synthesis by depressing delta aminolevulinic acid synthetase. And intermittent use of an inducer may interfere with adjustment of dose of another drug prescribed on regular basis. For example, oral anticoagulants, oral hypoglycemics, anti-epileptics, antihypertensives. These can cause precipitation of acute intermittent porphyria. So then coming to possible uses of enzyme induction. So congenital non-hemolytic jaundice. It is due to deficient glucuronidation of bilirubin. For example, phenobarbital hastens the clearance to jaundice. Then Cushing syndrome. Cushing syndrome, phenytoin may reduce the manifestations by enhancing degradation of adrenal steroids which are produced in excess. So possible uses of enzyme induction. You can induce enzyme induction to use in different diseases like congenital non-hemolytic jaundice. It is due to deficient of glucuronidation of bilirubin. Example, for example, phenobarbital can hasten the clearance to jaundice. And in case of Cushing syndrome, phenytoin may reduce the manifestations by enhancing degradation of adrenal steroids which are produced in excess. In case of poisonings, by faster metabolism of the accumulated poisonous substance, can do enzyme induction will be helpful. A faster metabolism of accumulated poisonous substance. These are the possible uses of enzyme induction. You can go through the book to learn more about this and also from different articles. Then coming to suicidal inhibition. Suicidal inhibition means suicide inhibition oblique suicide inactivation oblique mechanism based inhibition is an irreversible form of enzyme inhibition that occurs when an enzyme binds a substrate analog and forms an irreversible complex. So you can go through different books to learn more about this. Then coming to factors affecting drug metabolism. For age is also a factor affecting the drug metabolism. In case of neonates, they have low microsomal enzymes and glucuronil transferase. So for example, in neonates, when chloramphenicol is administered, which is primarily metabolized by glucuronil conjugation, leading to a life-threatening cyanotic condition called gray baby syndrome. In elderly, more than 60 years, uh, reduced hepatic blood flow is there. So for example, when drugs like propranolol and pethidine are given whose rate of metabolism is governed by hepatic blood flow, exhibit slow metabolism and increased incidence of toxicity. Then sex important in animal species but are seldom important in human beings. For example, male rats sleep for a shorter duration than females after receiving hexabarbital. Then species, examples of species dependent variations in drug metabolism are few. For example, rabbit metabolize atropine faster, more atropine storage activity in the liver and plasma in case of rabbit. So rabbit metabolize atropine faster. Then the racial differences in metabolism are less. For example, Chinese have high alcohol dehydrogenase but low aldehyde dehydrogenase activity. Genetic variation. Genetic defect in atypical pseudocolon esterase. The drug involved is succinylcholine and therapeutic use in case of neuromuscular blocker, and clinical consequence is prolonged apnea due to retarded metabolism. So if a patient having atypical pseudocolon esterase, then if he is given succinylcholine, then prolonged apnea due to retarded metabolism can occur. And another genetic defect can be slow N acetylation. In case of slow anesthetization patient, you use the isoniazid, then there will be that is used in case of anti-tubercular. In case of tuberculosis, then the clinical consequence will be peripheral neuropathy in slow anesthetization. In rapid anesthetization patients, if you tuberculosis patient, if you give isoniazid, then there will be chance of hepatotoxicity. And faulty expression of CYP2D6 patients, some patients there might be faulty expression of CYP2D6. If you give codeine, then the codeine for opioid as opioid analgesic for pain in the patient you are using codeine, then there will be clinical consequences like reduced analgesia. The analgesic power will be reduced if they have faulty expression of CYP2D6. So these are some examples of genetic variations of drug metabolism and biotransformation. Then coming to nutrition and diet. Diet rich in protein and low carbohydrate enhances the rate of metabolism of many drugs. Rich protein diet supplies glycine and cysteine, which are essential to form conjugated metabolites. And starvation leads to enzyme inhibition. So, in case of disease, the activity of hepatic cytochrome P450 enzymes are impaired to varying degrees in a number of pathological states of liver. Hypothyroidism decreases the metabolism of digoxin and methimazole, while hyperthyroidism enhances. Then drug-drug interactions. Enzyme induction and inhibition can lead to drug-drug interactions. Then Hoffman elimination is another important thing. Uh, Inactivation of the drug in the body fluids by spontaneous molecular rearrangement without agency of any enzyme is known as Hoffman elimination. For example, atracurium, etc. Atracurium, there occurs the inactivation of the drug in the body fluids by spontaneous molecular rearrangement without the agency of any enzyme. That is known as Hoffman elimination. You can go through different books and articles to learn more about this. Then coming to fast-pass metabolism definition, metabolism of a drug during its passage from the site of absorption into the systemic circulation. The site can be liver through portal vein and intestinal wall, and limited pre-systemic metabolism can occur in skin, that is in case of transdermal drugs, in the lungs, in case of drug reaching venous blood. And pre-systemic metabolism in the gut and liver can be avoided by administering the drug through sublingual, transdermal, or parenteral routes. So then coming to extent of hepatic fast-pass metabolism of some important drugs. The extent of fast-pass metabolism of some important drugs are low fast-pass metabolism in case of phenobarbital, phenylbutazone, tolbutamide, theophylline, pindolol, isosorbide mononitrate. Intermediate fast-pass metabolism, the drugs examples are aspirin, quinidine, desipramine, nortriptyline, chlorpromazine, pentazocine, metoprolol, and high fast metabolism. That's why not given orally are isoprenaline, lidocaine, hydrocortisone, testosterone, and high oral dose can be given in case of high fast metabolism. The examples are propranolol, alpranolol, verapamil, salbutamol, glyceryl trinitrate, morphine, pethidine, etc. So you can go through different books and articles to learn more about fast metabolism. So these are the references, and you can go through these Goodman, Gilman, Katz, and Katie Tripathi, Rangendel, and Lippincott, Wilkins books, and also you can go through different books, and if there is some other articles to learn more about this topic. So that's all for today. So please like and subscribe my channel and watch the video completely so that you can learn a lots of things from uh, my channel. So keep watching. Thank you very much. Jai Jagannath. So that's all. Thank you very much. Jai Jagannath.